Thank you for joining us today for our webinar, What is FPIES and How Do You Manage It? I'm Jennifer Gertz, Executive Director of Food Allergy Canada, and today our expert joining us is Dr. Anna Nowak. Before we get started, I want to note a few housekeeping items. Note that this session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar. We'd like to thank everyone who submitted questions on registration. There are some common questions that we will tackle in today's session. If you have additional questions, please submit them in the chat and question box throughout the webinar, and we'll try to get to as many of them as possible. And lastly, this webinar will be recorded and shared on foodallergycanada.ca afterwards. First, a little background on this session. Under the umbrella of food allergy are a number of different conditions that present with adverse immunological reactions to food. They can be IgE mediated, non-IgE mediated, or a combination of both. The most commonly known class of food allergy is IgE mediated food allergy, in which the symptoms result from the body's immune system making IgE antibodies. These antibodies cause the immune system to trigger an allergic reaction when a specific food is consumed, and the reactions are reproducible, typically occur quickly, and can potentially be life-threatening. Non-IgE mediated food allergy is a lesser recognized class of food allergy in which other components of the immune system react and doesn't involve IgE antibodies. This class of food allergy usually causes gastrointestinal related symptoms, and these symptoms do not appear immediately after consuming a specific food. However, the impact of this class of food allergy can be significant, leading to substantial declines in quality of life. Last month, we hosted a webinar on one of these types of non-IgE mediated food allergy called eosinophilic esophagitis, or EOE. And today's session is about another type of non-IgE mediated food allergy, food protein-induced enterocolitis syndrome, typically affecting young children and causing severe vomiting, paler than normal skin color, tiredness, and diarrhea. Such symptoms can be confused with those of other illnesses like a bad stomach flu, making the condition harder to recognize. Now, some of you may have joined us today because your child or your patient have experienced some of the common symptoms of FPIES, and you're trying to better understand how this condition is diagnosed and managed. Others may be tuning in because your child or patient has a formal diagnosis of FPIES, and you're wondering about how to go about introducing new foods and when and how to consider reintroducing the trigger food into the diet. So we'd like to start, before I turn it over to our expert, we'd like you to answer this poll so we understand who has joined us in the listening audience. So if you can select all that apply. So first, which situation best describes your situation? Your diagnosis with FPIES, you or your child, you suspect FPIES and want to pursue a diagnosis, you have patients with FPIES, or you have patients with suspected FPIES. So if you can take a moment to answer that poll question. All right, so we've got 19% of the audience that has a diagnosis of FPIES with a child or themselves. 20%, just over 20, suspecting FPIES and want to pursue a diagnosis. We've got 46% of our viewing audience actually have patients with FPIES, 38% having suspected FPIES. Okay, well, thank you very much for giving us some perspectives on who's joined us today. Now, I'm pleased to introduce our expert for this session. Dr. Anna Nowak is a pediatric allergist and immunologist, a professor of pediatrics at NYU Grossman School of Medicine, and director of Pediatric Allergy Program at Hassenfeld Children's Hospital in NYU Langone. I've had the pleasure of meeting Dr. Nowak several times at academic conferences throughout the world, and what we are very fortunate to have who I would consider one of the leading experts on FPIES internationally, who is very well published and has really taken a personal interest in making sure that the broader community understand this condition and how to manage it. So thank you so much, Dr. Nowak, for taking time out of your very busy schedule to be with us today. So I'll turn it over to you.
Thank you, Jennifer, for this kind introduction, and thank you to Food Allergy Canada for the invitation to talk to you about food protein-induced enterocolitis syndrome, or FPIES for short. Here are my disclosures. Really, they are not relevant for this presentation, except maybe for me being a chair of the medical advisory board of the International FPIES Association. So on my agenda is to define FPIES, to discuss practical approach to diagnosing and management, to describe what are the common trigger foods, strategies for food reintroduction, tell you about current approach to managing FPIES emergencies, and then touch upon baked diets, baked egg and milk diets for FPIES, and also leave you with some important take-home messages. So as Jennifer explained, food allergies are defined as an adverse reactions to food mediated by immune system. So this is different from non-immune food intolerances. And then among the immune-mediated, what FPIES is a part of is the non-IG-mediated food allergy. It is different from IG-mediated in the mechanism that is cell-mediated without evidence of systemic IgE antibody production, and also the sort of the kinetics of the response, with the symptoms being more delayed, but nevertheless can be quite dramatic. So definition of FPIES is that of non-IgE cell-mediated food allergic disorder that manifests with predominantly gastrointestinal symptoms of delayed, repetitive, and forceful vomiting that usually starts within 1 to 4 hours after food ingestion, and commonly at about 2-hour mark. It is frequently associated with sort of alarming appearance of the affected patients, such as low activity level, which we refer to medically as lethargy, pale or ashen skin. And in some patients, those upper gastrointestinal symptoms are followed by diarrhea about 5 to 8 hours from the ingestion of the food. And what is very typical or characteristic for FPIES is absence of cutaneous and respiratory allergic symptoms. So FPIES reactions are not associated with hives, with itching, with swelling, or coughing, wheezing, or shortness of breath, but can be associated with low blood pressure. So this is why FPIES is considered an allergic emergency, non-IgE mediated, but nevertheless allergic emergency, because some of the reactions can be very severe. So they lead to dehydration, metabolic derangements with metabolic acidosis, methemoglobinemia. If FPIES symptoms are chronic, then also can be associated with low albumin total protein, or anemia. Both acute and chronic symptoms can be associated with high white blood count with predominance of neutrophils. Some studies reported elevated C-reactive protein, which is a marker of inflammation. And then up to 20% of the patients may be in hypovolemic shock that is referred to as distributive shock. So it doesn't result from loss of fluids through vomiting, but more of a dilation of the blood vessels due to the mediators of inflammation. So the children or infants look very unwell. They look septic. They frequently are being undergo extensive testing in the emergency department. And the first reaction is typically misdiagnosed as an infection, usually viral gastroenteritis. I've started looking into FPIES more sort of in the beginning of my career. Was a long time ago. And about 20 years ago, 23 years ago, FPIES was considered a very, very uncommon condition, sort of a zebra in the world of food allergy. So we were quite surprised when we've conducted a population-based survey as a part of the larger study focusing on the IG-mediated food allergy, which was conducted by Ruchi Gupta and her team in Chicago. And in that survey, there was one question asking about the diagnosis of FPIES in a respondent or their children, with this sort of this note that this is a very uncommon allergic condition. And the question was about, have you or your child been diagnosed with FPIES by a physician? So the responses translated into an estimate that 0.51% of US pediatric population are affected by FPIES, and 0.22% of US adult population are affected by FPIES. So this was quite surprising to us and suggested that we are dealing with a much more common condition that previously estimated. And what was also interesting from that study was that patients reported very high rates of other allergic comorbidities, including Ig-mediated food allergy, eosinophilic esophagitis, asthma, as well as seasonal allergies, putting FPIES in that continuum of allergic predisposition. And there is even a more recent study that was done in a birth cohort in suburban Boston, which estimated cumulative incidence of FPIES over the 3 years at 0.9%. And this was a more recent, maybe 6 years after our original study was conducted. So this might also suggest there's potentially we're seeing an increase in prevalence of FPIES, at least in the United States. So I will discuss important sort of challenging aspects of FPIES in the context of a case. This is like a typical patient presenting to the allergist office, 8-month-old boy, exclusively breastfed, who has mild eczema, but it's otherwise healthy. Solids were introduced at 5 months old, and initially he was tolerating carrots and sweet potato without any problems. But when oatmeal was introduced, the fifth feeding, that was oatmeal mixed with breast milk and sweet potato, within 4 hours led to emesis, multiple 8 episodes associated with pale skin. The child was rushed to the emergency room and was diagnosed with viral gastroenteritis because there's no other explanation for the symptoms. And he also developed some loose stools the following day. But when the subsequent oatmeal feeding a week later with half an ounce of oatmeal mixed with carrots led to multiple episodes of vomiting, pallor, so pale skin and low muscle tone, and ended up in the intravenous fluids hydration in the emergency department, um, then was food allergy suspected, specifically to oat. However, following this reaction, the mother was afraid to retry sweet potato and carrot, and she eliminated carrot and sweet potato from her own diet during breastfeeding, even though Jack has never had any symptoms during breastfeeding. So this is not uncommon behavior among our patients, because those reactions are very anxiety provoking, and frequently the mothers, who are usually the primary caregivers, sort of self-diagnose a post-traumatic stress following those reactions, because children look very, very unwell. So the symptoms that Jack presented with are really consistent with FPIES. And I just want to review the formal diagnostic criteria proposed by the 2017 international guidelines for FPIES, which said that to make a diagnosis, we need one major criterion, which is that of vomiting and absent skin respiratory symptoms, associated with 3 or more minor criteria. So either more than 1 episode to the same food, repetitive emesis to another food, lethargy, so low activity, pallor, pale skin, emergency room visit, need for intravenous fluids, or diarrhea in 24 hours, usually 5 to 10 hours. So Jack has met those criteria, and for the acute FPIES. There's also a phenotype of a chronic FPIES, which accounts for less than 10% of all of the cases that are seen in the allergy practices. And this is usually described in infants who are in the first few months of life that are exclusively formula fed or rarely breastfed, when the symptoms are progressively worsening. So vomiting and watery diarrhea, and over time, if the feeding continues, it um, culminates in a very serious dehydration and even shock. But I guess the major point I should say also here is that we don't have a biomarker for FPIES. There's no blood test or skin test that helps us diagnose FPIES. This is a clinical diagnosis, same as anaphylaxis is a clinical diagnosis. So here's the time for our first question.
All right, thank you, Dr. Nowak. So this poll question, so in the case of with Jack, let's choose which solid food to introduce next. So if you can indicate which solid food you think should be introduced next, is it wheat, peanut, egg, milk, or peach? So when those results come up, I will share those with Dr. Nowak and we'll continue. So a couple more seconds. All right, so 24% of the audience has said wheat, 7% peanut, 11% egg, 9% milk, and 50% peach.
All right, great. So it will be a little, convoluted, like long answer to that short question. But basically, any food can cause FI, so similar to IG-mediated food allergy. But the most common foods are grains, cow's milk, vegetables, and fruits. Among grains, oat and rice, followed by wheat, barley, quinoa are most common. Among fruits, avocado, banana, apple. Vegetables, sweet potato, peas, and corn. And then regarding the single versus multiple food, that survey study on a large number of patients suggested that the majority react to one or two food groups, and only about 10% might react to multiple food groups. So what is important to recognize is one is that Jack has really great chances of tolerating the next food, and also that I should also mention globally, cow's milk is number one, followed by soy, by egg, grains, and the countries where seafood is being introduced early into infant diet, um, there are cases of solid food FYs to fish. But generally, those tend to be the FYs triggers tend to be the first foreign food proteins that are introduced into the infant diet, because FPIES typically starts in the first year of life, although it may also start in older children or adults, but then it's more typically triggered by seafood. So here I think is the most important slide to answer that question, is that there is some risk of co-reactivity in FPIES. We are not sure if it's really truly cross-reactivity, but we know sort of empirically that if a child reacts to one grain, they have about 40–50% chance of reacting to another grain shortly after that initial reaction. If they react to milk, they have about 40% chances of reacting to soy and vice versa. And then the chances of co-reactivity to fish, different type of fishes, or between fish and shellfish are higher. So the bottom line is that if you're dealing with a patient who had such a significant reaction, you would like to choose a food that has the lowest risk of cross-reactivity, so, or co-reactivity. So it wouldn't be it would not be a grain, right? He reacted to oatmeal, to cereal grain. So you would not introduce that as the next food. Subsequently, after you have introduced fruits or vegetables and introduce other meats, you will go back to, we would go back to other grains, but it wouldn't be our first choice, just because we don't want to sort of traumatize that family and that child more. It's not uncommon that after a reaction, the child starts exhibiting difficulty feeding and refusing new foods, new textures. And we think that this is due to that, very unpleasant experience during a reaction. So, so the better choice would be a fruit or a vegetable, and then a meat. And then what is important is that, you know, when you introduce that first food following an acute reaction, or when you go on to introduce the first cereal, we generally endorse a gradual schedule, but it's only for that initial introduction. Subsequent food introductions are much more liberal. And for peanut and egg, would definitely recommend introduction in the first year of life, according to the overall recommended guidelines for early introduction for prevention of IG-mediated food allergy. So we've published that during the pandemic, and this is an approach that I've been using in my office that parents really like having very specific instructions. This is very empirical. This has not been studied in randomized clinical trials, but essentially the recommendation is start from a small amount, like a quarter of a teaspoon, but feed the child once or twice a day. If it's twice a day, then we recommend feeding in the morning and around lunchtime, at least with 6 hours in between to account for any delayed symptoms. And then the patient would stop subsequent doses if child develop any gastrointestinal symptoms. And then there could be, you know, variation of that approach with, you know, just doing it over the weekends, twice a day, and just once a day during the week when the child is in daycare, parents are working. And then they continue this sort of escalation until reaching a serving size that is appropriate for the infant's appetite and ability. Usually it's 1 to 3 tablespoons of meat, 2 ounces of fruit or a vegetable, or 1/4 to 1/2 cup of grains. What is important that what we enforce among the patients is that they should continue feeding that food at least twice a week going forward while adding other foods. And this is based on observation that sometimes FPIES symptoms develop after initial introduction is followed by a pause because of either infection or travel or introducing other foods. So again, this is very empirical, but it seems that this more regular dosing has a more favorable outcome. These are some new kids on the block. So in the US, we are now seeing more of the peanut FPIES, more tree nut FPIES, and much more of egg FPIES. This is also true for countries like Japan, that they are talking about the epidemic of egg FPIES. And the most recent data published earlier this year from our colleagues in Ann Arbor in Michigan do really show that the majority of solid foods or reactions are triggered by oat, then by rice. Number 3 is dairy, number 4 is egg, and number 5 is peanut. So now these egg and peanut have, you know, eclipsed the other solids like you know, sweet potato, banana, or, you know, other vegetables that were before recognized and frequent culprits. And obviously we are concerned that maybe early introduction of those foods for prevention of IgE-mediated food allergy may be playing a role. However, considering, you know, sort of weighing the risks and benefits, it's still strongly advisable to proceed with the introduction of peanut and egg and other nuts in the first year of life for prevention of the IG-mediated food allergy that is much more common than FPIES. So here is the next polling question.
So on this one, we would like you to answer the question of when to introduce an FPIES food trigger, time from the most recent reaction. So is it at 3 months from the most recent reaction, 6 months, 12 months, 24 months, or it depends? Let's see what our audience has to say on this question. All right, couple more seconds. And we've got 16% of the audience saying 3 months, 21 at 6 months, 21 at 12 months, 5% on 24 months, and over a third answering it depends. All right, back to you, Dr. Nowak.
Thank you. I was just saying that it's really Natural history is very favorable. Majority will outgrow their FPIES by age 3, with the exception of the fish. And really, there are no studies to evaluate different reintroduction schedules. So the timing of reintroduction is really based on the nutritional and social importance of food. Obviously, foods like milk or egg or even peanut are nutritionally as well as socially important, but things like oat are not necessarily the most nutritionally important foods. But for instance, in the US, Cheerios is the very common food, very common snack. So this is the driving kind of force behind the willingness to undergo evaluation for the tolerance to oat. Um, and in addition to fish, potentially shellfish, there's also a question about egg and peanut and tree nuts. Will this FBIES to those foods take longer to resolve? These are the food allergens associated with the most common food allergens involved in the Ig-mediated food allergies, and tend to have a more persistent course. And indeed, our colleagues from Australia have shown that in addition to fish, egg was also um, rarely outgrown by age 3. So they suggested that perhaps delaying the introduction of lightly cooked egg until age 5 may be the most appropriate approach. But in general, you could even do a challenge or reintroduction in 3 months if the reaction was mild. Obviously, if the reaction was very severe, which was associated with treatment with intravenous fluids, admission to the hospital, or if the symptoms were induced by a very, very, like a trace amount of food, which is uncommon for FIs because in let's say in cow's milk FPIES, majority of infants will react after ingesting at least an ounce of milk. Um, then those, would suggest that in the future the symptoms may be also more severe. And when it comes to the current reaction, if the patient ingested a high dose of food, then we also worry that they may have more violent symptoms, um, if as opposed to a situation where they ingested a much lower dose of the food. So really, in terms of the studies, the one study have identified the prior severe reaction being the most predictive of the future severe reaction. So if you have a patient who has been treated with intravenous fluids or admitted to the hospital or to the intensive care unit, this is the person that you really have to, um, think hard about introducing foods at home. So if we have a patient who has an accidental reaction and develops the acute symptoms within a couple of hours, it is important to recognize that we should resuscitate those patients. And then depending on those risk factors, be ready to provide intravenous fluids if the patient has had risk factors or is having severe symptoms right now. So the management of FPIES is different from the anaphylaxis or Ig-mediated food allergies. Again, no randomized clinical trials, but there's a clinical experience that sometimes we have patients who have Ig-mediated food allergy to one food and then develop FPIES symptoms during a challenge. And then when you use Benadryl or intramuscular epinephrine, it does not really improve the symptoms. So the best strategy is rehydration, using ondansetron, which is antiemetic that can also stop vomiting in milder symptoms. It can be given by mouth as injection into the muscle or into the vein, and into the vein is most effective. And also using methylprednisolone. So it's a steroid. We use a single dose because the more severe the symptoms, the more strong inflammatory signature during that reaction. So there's this, generalized activation of the immune system in the whole body. And then this a single dose of steroid can help calm it down. And the patient resolve within few hours or max 24 hours when this is an isolated exposure in acute reaction. And what is important to recognize is that not every reaction needs emergency room evaluation and management, and some of those reactions can be treated at home. So again, there's some silver lining to the COVID pandemic. When we published sort of our approach during the COVID pandemic to sort of stratify the reactions, if the reactions are milder or the patient hasn't had any serious symptoms in the past, we would manage at home. We didn't want to send patients to the hospital to wait in the emergency room for hours and be exposed to COVID virus. But it seems like this may be a reasonable approach also under normal condition. So the first choice, if the patient is responding well, is not lethargic, to try oral rehydration with clear liquids or breast milk, starting from small amounts such as ice chips or 1 teaspoon every 20 minutes, and advance is tolerated. And if the patient is tolerating this well, then can be monitored at home. But if the symptoms are not improving or the patient is really having continued vomiting, lethargy, or signs of dehydration, then we would enforce evaluation or calling 911. And of course, if the initial symptoms are severe. So just to again show, what is the difference between mild, moderate versus severe reaction, or the patients undergoing a current reaction. So the patient who has had no prior severe reactions and is having less than 3 or fewer episodes of emesis, and is able to tolerate small amounts of liquids by mouth and has normal activity, normal muscle tone, body temperature, and skin color, this patient can be managed at home and well recovered within several hours. So within um, uh, there's no need to take this person to the emergency room. However, if they had prior severe reaction, admission for the intravenous fluids or intensive care unit, admission, we recommend that such a patient activates emergency services as being evaluated by a physician. Um, but if the current episode is also associated with 4 or more episodes of vomiting, associated with low activity level, lethargy, floppiness, low body temperature, or pale ashen skin color, this would be the indication for seeking medical attention because the patient may need intervention with intravenous fluids for resolution. As we're seeing more and more patients with FPIES, we are um, asked by parents to provide emergency treatment plans. So we are currently developing a action plan for FPIES similar to anaphylaxis, that is advising the caregivers what to do with the doses of ondansetron that can be given, with the understanding that ondansetron is not 100% effective, that the more severe symptoms will not improve, but at least it's an explanation that giving Benadryl or epinephrine intramuscularly is not going to be helpful in those patients. And finally, one of my other favorite topics is the baked milk and egg diets in food allergy. So we have always recommended that patients with FPIES avoid all forms of milk, and this is based on the knowledge of the pathophysiology of FPIES, which is a cell-mediated reaction with patients reacting to mostly sequential epitopes that are not being destroyed by a high temperature and baking. But it turns out that actually there is a subset of patients with FPIES who might tolerate baked milk and baked egg. And those are small studies. The first study regarding baked milk is from Israel. And it has excluded patients with prior severe reaction. And but among those who did not have such a severe reaction, 8 out of 11 passed the baked milk food challenge successfully. So I think this remains to be reproduced by other studies and in other patient populations, but it's encouraging to see that potentially we could open up the diet of those children with milk FPIES, and also similarly to the IG-mediated food allergy, infants who can tolerate baked milk, infants with FIs tolerating baked milk probably have much more favorable prognosis and would outgrow their milk FIs faster than those who react to the baked milk. In similar experience has been reported by our colleagues from Italy, saying that among children with the egg FPIES, so children reacting to scrambled egg, there's a subset of them who can tolerate egg that is baked into a muffin or a cookie. And generally, they said that of those, more than 50% of the infants tolerated, actually 77% tolerated baked egg at the mean age of 30 months. And then those who had reacted to baked egg didn't have severe symptoms. So I think this is very encouraging and potentially giving us a new direction in opening the diet. And I know in Canada, the ladders with the egg and milk are quite popular. And they're being used in different various forms of milk and egg allergy. They were initially developed for the non-IG mediated food allergies such as fructocolitis or enteropathy. And it might be that patients that have really mild symptoms in FPIES could be advanced according to that latter approach, which starts from a slow doses of extensively baked products with milk or egg, and then gradually progressing to foods that have higher protein content and are less well heated. Which potentially could be done even at home. Although if the patient had a severe reaction to milk or egg, I would strongly advise against introducing those baked products at home as a ladder, only after having this done under physician supervision, it would be advisable. So I just also want to mention a few words about the adult FPIES. We know that it can start, vast majority of FPIES cases manifest in the first year of life. Some adults or older children may experience also reactions, FPIES reactions to seafood, particularly crustaceans, fish, and mollusk, but also rarely reported FPIES reactions to dairy, wheat, and egg. And most of the time, those are acute symptoms. And what is very curious or very interesting about adult onset FPIES is that the most constant symptom is dramatic severe abdominal pain starting within the same 1 to 4 hours, and is accompanied by nausea. And not every patient develops vomiting, but there could be even loss of consciousness for some of those patients. It usually starts in young adults, but the onset has been described in older adults as well. Without exception, all of those patients have tolerated those FPIES foods before, so they used to eat that, and we don't know what breaches the tolerance that they have established before. And also, curiously, the vast majority of the patients are female, which is in contrast to the FPIES in infants, which has equal sex distribution or even more male predominance. And the diagnosis of it in adult FPIES is delayed significantly. Some studies report as many as 8 reactions before food allergy is suspected. Again, because of the lack of the typical allergic symptoms and the delayed onset, and usually those symptoms are being misdiagnosed as food poisoning. The natural history is less favorable, with only minority of the patients becoming tolerant over the 3-year period, uh, in adults. So my take-home messages for you are that as physicians, as clinicians, we should manage FPIES proactively and avoid unnecessary food introduction delays. The management should really involve the caregivers and follow shared decision approach. And the goal should be to empower caregivers by providing clear guidelines for new food introduction. And to do that, it's also important to educate the caregivers that infantile FPIES is a very favorable natural history. And when we are choosing the new foods for introduction or reintroduction, we should take into consideration nutritional and social importance of those foods. Remember that those who had severe past reactions are at higher risk for future severe reaction, and the reintroduction should be more cautious. And also, the new evidence suggests that a subset of children with milk and egg FPIES might tolerate baked milk and egg. However, the initial introduction should be done under physician supervision, particularly in those who had past severe reactions. And with that, I will thank you for giving me this opportunity to talk to you, and I'm happy to take any questions.
Terrific. Thank you, Dr. Nowak. I'm going to ask you to turn your webcam on. Perfect. Great. Well, thank you very much. That was a very interesting presentation and a lot of knowledge for our listening audience. So we've had some questions submitted. So I'm going to start with some that are related to introduction and feeding. So this one here, we have someone in the audience who's asked about suspected FPIES after giving baby formula. So what are the strategies for introduction, when and how, and is there any category of formulas that they should be considering?
So generally, if the baby reacted to a cow's milk or soy-based formula, generally the preferred formula is that of extensively hydrolyzed. Hypoallergenic formula is the safest. And the younger the infant, the higher the risk of the co-reactivity with soy. So soy-based formulas are not considered hypoallergenic. If there is a concern for cost or availability or taste, etc., you could consider formulas that are not considered hypoallergenic, such as soy or partially hydrolyzed whey, but being aware that those may have higher risk of reactions. The reintroduction really depends on how severe the symptoms were. If the symptoms were mild, you could think about reintroducing it within 6 months, by the age 1. If the symptoms were more severe, then you may want to delay it, for up to a year or so. And then after a year, in addition to infant formulas, sometimes we use beverages, the plant-based beverages. If the child has otherwise a complete diet, some beverages like pea protein-based beverage might be appropriate for those patients. However, we always involve a nutritionist or dietitian when we are making those choices. So extensively hydrolyzed or amino acid is the safest bet, although amino acid is rarely needed in patients with FPIES.
Perfect. Okay. Now this question, I know you've touched on this again, but I think it's worth restating it. In this case, there's a patient with a 6-month-old baby with FPIES to egg. Can they still be introduced to other highly allergenic foods, especially peanut? Now, so I know you've touched on that, but I'd like you to talk about, or restate that, and also some advice on how to do that.
So that's a very good question, and I would say in that situation, it all depends on what are other risk factors for the IG-mediated food allergy for that infant. Because if they have no risk factors, so there's no severe eczema, you're not worried because there's peanut allergy in the family, which by the way is not an official risk factor, but
Right.
people worry, right? Like if you have an older child that is peanut allergic. I would then introduce some other complex proteins like meats or grains or even fish before proceeding with the peanut. But I would still do it in the first year of life, so I wouldn't delay it, because if the more foods this child is tolerating, this baby is tolerating, the more confidence I have that they're going to tolerate and not so peanut. So I wouldn't delay it, past the first year, but I wouldn't follow that reaction to egg, right? With the introduction of the sort of the highly allergenic food, because to me that suggests that this baby is having problems with the complex proteins. And so then it's just empirical that the better approach would be to use something alternative to see, okay, are they ready now? In the FPIES, it's really funny. It almost seems like, there's a time and the food, and if you sort of bypass that period of vulnerability, kids do better. So even delayed introduction by 2 months can make a huge difference. How I would introduce it, I would just introduce it slowly, So, okay, you're going, introduce peanut. You'll introduce from that, that approach. You start from a quarter of a teaspoon of a peanut butter mixed with breast milk or, or formula or baby food. And then double the amount with every feeding, either once or twice a day until you reach at least a teaspoon. Um, and then you continue twice per week. Or you could, if the baby already introduced corn, then we would start from something like bamba, right? Like, those or the corn puffs, other types of the peanut puffs
Right.
that are available, just to make it easier. But the consistency is important. So similar to the IG mediated food allergy, the trick is not that you try once or twice and then you say, yeah, I've introduced that. No, the trick is to continue being very consistent.
Okay. Terrific. Okay. Now there is another related when you were talking about inheritability of peanut allergy. One of the questions that came up is if one child in the family has FPIES, do we understand what the possibility or the chances are of other children in the family also having FPIES?
It's higher than general population. Probably, I cannot give you like, okay, it's a 5 times higher. It is higher than the general population. We know that. It's just hard to put like a number on it. But definitely, I've seen now families then the mothers or fathers have FPIES, but I have to ask them because sometimes they don't volunteer that information or they have EOE. So I'm asking specifically, anybody in the family diagnosed with the same condition, and they report it. And sometimes there's our mothers who develop that after pregnancy, so suggesting hormonal, you
Right.
know, changes underlying that phenomenon, or like diet that includes very high amounts of that particular food, like egg, but it is higher. So yes, there will be a bit of a higher risk if you have a family history.
Okay. Now, what are the symptoms of, or I guess, are the symptoms the same in FPIES in the context of a baby that's exclusively breastfed? Can you speak to that? And also, kind of how that should be managed if it's, and whether the mother should be taking steps on their diet?
So in general, symptoms during exclusive breastfeeding, so to the food that passes through the breast milk, are uncommon. So we don't prophylactically recommend avoiding the food that the baby reacted through direct feeding in the maternal diet. However, and we know that the amount of the protein, like recognizable allergen in the breast milk, is very, very low. I have to say that in my practice, I've seen one case of a baby with chronic FPIES that developed during exclusive breastfeeding. And this developed over weeks to months when the baby was fed, and the symptoms would be intermittent vomiting and water stools and not gaining weight. And if you see something like that, then depending on the severity of the symptoms, definitely the first discussion would be to eliminate milk from the maternal diet. Um, or if for whatever reason this is not possible, or you're not sure whether it's milk versus other food, then you could consider switching the baby to the hypoallergenic formula, although the preferred approach is to see, hey, can we modify the maternal diet so the baby continues to have benefits from breastfeeding. um, I have not personally, I have never had a baby who had acute FPI symptoms through the breast milk. And this is probably because the amount of the allergen in the maternal milk is very, very low, but it may be enough to drive more chronic symptoms. But then, it really becomes of a difficult situation because you don't know unless you challenge that baby, right? Like, unless you then give them milk, let's say, directly, which almost never happens because the parents don't want to do it.
Right.
No matter how they would rather defer it, until the baby's older,
Mhm.
because once they feel better, they start gaining weight, they just don't want to rock the boat. And then by the time we introduce this, when they're a year old or older, they might have outgrown it. So it's always sort of, in retrospect, presumptive diagnosis.
Okay, so now you mentioned around that FPIES can show up after numerous safe exposures to food. And in the case of Jack, right, the example you used 5 times before that reaction happened. How common is it that it's after multiple exposures to food? Do we know?
I don't know if anybody quantified that. I would just say that the more patients like I see, um, like the more stories like that I elicit, because before it was really first or second, or third exposure. So I cannot tell you, but I like sort of guesstimating, I would say less than 20%. So 1 in 5 might have multiple exposures. And I know that is creating a lot of anxiety because, how do you know that when we do a challenge or when you reintroduce, they are not going to have symptoms? The only, or not the only, but I think the important thing is that when we reintroduce, or those children, those babies are older, and every month decreases the risk of FPIES in those babies. Seriously, like I don't know how many patients I have with FPIES that starts after 12 months of age or after 18 months of age. It is possible, and I'm sure it will happen, to somebody. But in general, I would say 95% of the patients is under, the first, I would say between 6 and 10 months, and certainly within the 12 months of age. Um, that that's when these reactions happen. So if you reintroduce 6 months later, the chances are that the child is going to tolerate it very well.
Right. Okay. So let's talk a little bit about oral food challenges for FPIES. Okay. And, you know, um, maybe you can talk to us about, when should that be considered? I know you've covered some of that off, and then when are the situations where, you should do that at home? The oral food challenge can be done at home, or where should it be in hospital? And is, having intravenous access important?
So I think that it's a bit of a tricky question because there's no consensus, right? I mean, in the past, we always said, okay, it has to be done in the hospital. It has to be done with the IV fluid, IV access. And I think this reflected a selection bias because before, FPIES was being recognized well or more widely, the patients who were referred to the allergist were the patients who are most severe and those patients who had more severe symptoms. So it's hard for me to justify a challenge in the hospital with the IV fluids in a baby that had 4 episodes of vomiting after drinking 5 ounces of formula, and recovered at home. Why, what I mean? Like, so if they really had mild symptoms that recovered at home with oral rehydration to a large amount of sort of measurable amount of food, and the parents are up for it, so they decide they want to try introducing at home. I would do it at home, and I would use like a ladder approach, right? I would sort of very slowly, very gradually. However, if this infant ended up in the emergency room and was resuscitated with IV fluid, I'm not going to be doing this at home. I will do it in the hospital, and I will want to have the IV, the IV access at that challenge, because I have to give them a substantial amount of food during the challenge. I cannot give them a tiny amount, like as I'm doing at home over a period of days or weeks. I have to give them something, you know, we can work with to say, okay, this child, at least a third of a serving for age. And then the higher the dose, if they react, the higher the dose, the more severe the symptoms.
Okay, one last question is all I think we have time for, and it's around whether foods with may contain warnings, like how strict do you have to be with your FPIES triggers?
I don't,
Right. Okay.
unless
So you
unless you
don't what? You don't avoid it?
I don't recommend avoidance of precautionary labeling
Okay.
unless you had somebody who had the reaction, like bad reaction to a trace amount. But I would say 99.9% of the patients don't need to avoid precautionary labeling.
Awesome. I know there will probably be many more questions that if we had more time, but respecting the amount of time you've already given us and your very busy schedule, I'd really like to thank you for joining us. And I'm just going to go through a few other slides and just wrap this session up. So thank you very much,
Thank
Dr.
you.
Nowak.
Thank you.
So just in terms of the other comments and just closing off this session today, we'd like to thank you for joining us today. We've got some other things coming up, but we would like to make sure we get your feedback on this session. You'll get a short survey through GoToWebinar that asks you for your thoughts about today's session. Please take a moment to complete the survey as it helps us improve our programming and provides us with insights on other topics that you'd like to have us cover. There is more information and resources on FPIES on our site. You can see the link there for that information on the page here. And note that Giving Tuesday is coming up on November 28th. So please consider a donation. We can't do the work we do, like offering the free webinars just like this one, without your support. So we thank you for consideration on that. In terms of what's coming up next, we have one more webinar before the end of the year. On December 12th, we'll be covering a topic on food allergen immunotherapy and desensitization with Dr. Philippe Bégin. For more information and to register, please go to foodallergycanada.ca/events. And lastly, we'd like to thank our supporters for this webinar. This particular webinar was supported by the Schroeder Foundation, the Sean Delaney Memorial Golf Classic, EpiPen, and the Peanut Bureau of Canada, and made possible from the donations of viewers like you. So thank you for your participation in today's webinar. You can view the recording of this webinar at foodallergycanada.ca shortly. Please also share this with others who may benefit from this content. This now concludes our webinar.